Hello and welcome to our Science Review of the Year. I'm Fearghal McKinney, Head of British Heart Foundation, Northern Ireland. This month, as we approach the end of the year, we're going to look back on 2022 and review some of our biggest research breakthroughs and hear from some of the outstanding scientists who've been instrumental in these developments. But first, as we do in all of these, we'd like to gauge your current understanding of what research the BHF has funded this year. So our poll question, would you rate your understanding as very good or poor? So if you would like to click on the link that should be coming up, rate is 1 to 5, 1's very low and 5 is very high. Just give you a little minute to complete that. And in the meantime, let me introduce our first speaker, BHF Associate Medical Director for Research, Professor James Leiper from University of Glasgow's Institute of Cardiovascular and Medical Sciences. We'll be reviewing our BHF-funded research successes of 2022. James.
So thank you very much, Fearghal, for the introduction, and delighted to be here at this pre-Christmas live and ticking event. So for those who are regular viewers, you'll know that each month we try to bring you the latest BHF news and the pioneering research stories to this live and ticking series. And as Fearghal said, towards the end of the year, we like to look back on some of the breakthroughs that BHF funded research has made, and we like to hear from some of the outstanding researchers who are actually doing this research with funding from BHF. And so if I move on to the next slide, I'm going to do the Chris Whitty next slide, please, type routine. I just wanted to introduce 3 of my personal favorite research projects from 2022. The first one is an injectable gel to repair damage to the heart, and I'll talk a little bit about how that works and why I think that's important. Secondly, I want to tell you about researchers that have identified some proteins which could prevent the damage to a heart following the heart attack. And as many of you will know, heart attack is a very too common an event in the UK. So if we could prevent that damage, that would be great. And then the third story is one around statins. And a lot of you will have heard about statins, drugs that are very commonly taken to lower cholesterol levels, but are thought to have some side effects. And we funded some work which actually can explode that myth. So those are the 3 things that I thought I would choose to introduce to you. So if we could go on to the next slide, please. And I'll start with an injectable gel to repair damage to the heart. So this takes me back to the summer when we were in Manchester at the BCS meeting. And this is work that I'm particularly interested in because it was done by one of our PhD students. So one of the breed of new talent that the BHF brings into the scientific fold and supports throughout their early development. So in this case, Catherine King, who's a PhD student in Manchester, has been working on developing a gel that will repair the heart. So for a long time now, we've been thinking that if you could, following damage to the heart, if you could inject new heart cells, these cells may be able to strengthen the heart and to repair the damage. The problem is that when you inject these cells, very few cells actually remain where you want them to be. They get washed away by the blood flow and don't stay in the place that you want them to. So Catherine's pioneering work really is to make a gel that will keep those cells in a healthy state in the heart so that they can do their work. So on the next slide, we just move on to the next slide. I'll just take you through a little bit of the information on heart failure. And on the left-hand side, you can see a cutaway of a healthy heart with the right and left ventricles indicated. And on the right-hand side, you can see, I hope you can see, the heart following heart failure. So what you'll notice if you look at the left ventricle is that you can see it's larger than in a healthy heart. And you might think large is good, but it's not in this case because the wall of that ventricle is thin. And that leads to a very inefficient heart muscle that can't properly pump the blood around the body. Now, it's estimated that around 900,000 people in the UK alone are living with heart failure. And this has a significant effect on their quality of life, but also their length of life. We see these changes in the heart following conditions such as a heart attack, which many of you will know from personal and family experience is a devastating event. What we want to try to do is to find ways of stopping that damage to the heart, stopping the transition from the normal heart structure to the failing heart structure. And what we hope is that the gel that Catherine's been working on, together with novel heart cell technologies, will allow us to position healthy cells in the wall of the heart following damage, and therefore to stop this heart failure, which we often see after heart attack. And in this way, we'll allow the heart to regenerate. And this is our goal, regenerative medicine to repair and correct the damage following a heart attack. So very exciting research, very exciting to see new cardiovascular scientists coming in and making these wonderful discoveries. I want to move on now to a different technology that's been pioneered by Professor Mauro Giacca, who's Professor of Cardiovascular Sciences at King's in London. Now, Mauro's been interested again in preventing damage and regenerating the heart following injury, but he's taken a slightly different approach. So what Mauro has done is utilized a novel technology called FunCell, which allows you to search through all of the human proteins in a database and try to identify ones that might be therapeutically useful. And the idea here is that if we could identify these proteins, we may be able to inject them into the heart very close to the time when somebody's had a heart attack and stop the damage occurring in the first place. So whereas Catherine's technology is trying to regenerate hearts after damage has taken place, Mauro's approach tries to stop or to limit that damage in that immediate time around the heart attack. So using this approach, Mauro's identified 3 proteins, which he's shown in preclinical models can prevent and attenuate, so limit the damage to a heart following a heart attack. We think that this is, again, fantastic technology that shows the power of our researchers harnessing in silico database screening for novel therapeutics and then demonstrating in clinically relevant models that these have potential therapeutic efficacy. Again, very exciting research. So if we just move on to the next slide, I want to talk a little bit about heart attack. And heart attack, I think people's understanding of what a heart attack is differs widely. And so this is a little bit of an opportunity to talk about heart attack and heart failure. So it's not commonly known, but every 5 minutes, somebody is admitted to hospital with a heart attack in the UK. And that's a kind of a staggering number. And when somebody has a heart attack, basically the blood vessels that supply oxygen and nutrients to the heart are blocked, and the heart is starved of oxygen. And you can see on the right-hand side of this diagram, you can see a blocked blood vessel. And what's blocking it are fatty deposits called fatty plaques that build up because we have too much cholesterol circulating in the blood. So the buildup of these plaques limits the perfusion or the delivery of nutrients to the heart and can cause a heart attack. Heart failure is the primary cause of death and disability globally. So it affects around 64 million people worldwide. These numbers are staggering. And so it's really, I think, heartening to hear about the work that Mauro and Catherine have done to spearhead new types of treatment, which will protect the heart and minimize the damage to the heart should a heart attack take place. So I think those 2 studies really piqued my interest when I heard about them, and I wanted to share those details with you this evening. The next study I'm going to move on to on the next slide is slightly different. So statins are drugs which are very commonly used to lower cholesterol. And as I showed you in the last slide, the buildup of cholesterol in our blood vessels can lead to heart attacks. So very many people who have elevated cholesterol levels are put on statin treatment. And it's very effective. It lowers cholesterol and it lowers risk of heart attack and other cardiovascular diseases. However, a number of people who are taking statins have complained of side effects. And two of the side effects that are most commonly reported are muscle pain and muscle weakness. And this actually has led to people stopping their statin therapies, which is really worrying because we know that statins reduce your risk of heart attack. So we don't want people to stop taking statins. So to address this, we funded researchers to look at 23 very large studies from cholesterol treatment trialists, including information from 155,000 people, so a massive study, to assess the effect of statin therapies on the frequency of muscle-related symptoms across many different patient groups. And what was very heartening was that the results of these studies showed that you are no more likely to suffer muscle pain and muscle weakness if you're taking a statin compared with if you're not taking a statin. The figures for muscle pain and weakness reported in those two groups are almost identical. So we're very confident that we can say to people now that statins are very effective drugs in lowering cholesterol. They reduce your rate of heart attack and heart failure. And we can now say that they do not cause significant side effects in the vast majority of people that take them. That's not to say that any drug is without any side effects, but this new research shows that statins are safe for the vast majority of people and actually confer a very significant reduction in cardiovascular risk for those individuals. So I thought that that was another nice study to show, slightly different from the first two, but a really important piece of work that hopefully will reassure people that these therapies are safe and efficacious. So moving on to my final slide now, I just wanted to have a little look ahead into 2023. We will continue our series of live and ticking events, and our next one is scheduled for January. You'll be able to find details on the webpage. And this is going to look at heart health and the gut. And many of us may not have associated previously that actually the function of our gut and the dysfunction of our gut is related to your cardiovascular health. And so new research now is showing that the gut and the heart actually do talk to each other, and a greater understanding of how they interact will allow us to understand cardiovascular disease and find new treatments and therapies. Following on from January's heart and gut live and ticking, there'll be a whole series of new initiatives which you'll be able to find details of on our webpage. So I think that's probably enough from me this evening. I think I'll hand back to Fearghal now, who's going to introduce you to some of our new, young, exciting researchers who can tell you a little bit about the work that they've been doing. Thank you very much.
James, thank you very much and for highlighting some of the really interesting science successes of the year. And as you say, we have more coming up. And can I now introduce you to Professor John Simpson and his colleague Natasha Stephenson, who'll talk about their virtual reality technology that they've developed to improve heart surgeries. John and Natasha.
Perfect. I hope you can hear me okay and you can see my screen. My name is Natasha Stephenson. I'm, as you've already introduced, I'm a research fellow working with Professor John Simpson and team here at King's College London and Evelina Children's Hospital. I'd really like to thank the British Heart Foundation for asking us to speak at today's live and ticking event. So thank you very much for having us. And we're going to be talking about virtual reality for planning heart procedures and the work that we've been doing in the past few years. I'm just going to try and move on. Oops. There we go. Sorry.
Sorry. Okay. So I'm John Simpson. I'm a pediatric and fetal cardiologist. I've been in this for over 25 years, and my research has been in 3D and 4D, which means moving 3D images, for over 20 years.
And I've already introduced myself. I'm working as a research fellow in cardiovascular imaging on this project, and I'm in training as a pediatric cardiologist. So we wouldn't really be well placed here without mentioning the whole team who've been involved in this project. So we're just a small part of the overall team. So in green here, you can see the clinical members of the team who are doctors and clinicians who work in this field and have been helping us with the project. And in blue are our engineering colleagues who have helped to who developed the system and have done all the engineering work. So I'm just moving on to talk a bit about the background of the project. Just talking about congenital heart disease. So what is it? So congenital heart disease is a problem or problems with the structure of the heart which develop in utero before and are there when the baby is born. So it can be there because of a problem with the development of the veins, the arteries, the heart valves, or one of the chambers or the walls between the chambers of the heart. And we know that it's a very common problem. So not many people know this, but it can affect up to 1% of live births worldwide. So it's a very common problem it causes a big problem worldwide. So congenital heart disease it's usually a treatable problem, and the major interventions that we can do to treat these problems are with either open heart surgery or surgical interventions, or with minimally invasive or catheter interventions. We perform over 10,000 of these procedures a year in the UK. In order to provide the best care and choose the best intervention for the child or the person with congenital heart disease, we need to do some planning. The best way that we do this is with imaging. So this has been a major development in the past 20 years. Cardiac imaging has come a long way. So as you can see on the left of the screen, what we initially were using previously was two-dimensional imaging. So two-dimensional imaging just allows us to see a slice through the heart. So you can see at the top is an echo image, which is an ultrasound image of the heart, which allows us to see 2D slices of the heart. And on the bottom of the screen, we can see an MRI scan, which again allows us to interrogate the heart in 2D slices. And over the past kind of 10 or 15 years or so, we've been able to develop three-dimensional pictures. So what this does is reconstruct the image using kind of lighting and coloring effects on your 2D screen to create a three-dimensional type image reconstructed from these 2D slices. But as you can see from these pictures, although they do look much better, what you're still seeing is a reconstruction on a 2D screen. And so moving forward, we've been generally people have been trying to create ways that allow us to understand the heart better in 3 dimensions. So again, more recently, 3D printing has been a major revolution in planning for structural interventions in the heart. And you can see here that although it gives you a much better idea of the 3-dimensional structure of the heart, you can hold it in your hands and you get a much better understanding. You can move it, you can really understand how the heart is put together and the planes of the heart and how they fit together. But there are limitations to this. One of the major ones being that it's very time consuming to produce these models. Firstly, you have to do a lot of image processing, which can take many hours, and then you actually have to print the model, which can take days to weeks to months, depending on the timescales and where you are. As you can see, it's a plastic model, and what you can't do is get that dynamic motion of the heart, which is so important for understanding how you're going to plan heart procedures. You can't see the pumping, you can't see the valves. So this is a major limitation of 3D printing. And so what we've been moving towards is different options for this real 3D understanding of the heart. And so virtual reality offers a lot of positives that you can't have in any other modality. So what you get with this is you get complete immersion in a closed headset that you can see here in the picture on the left. And you interact with the true 3D image, which is displayed in your headset, and you can interact with it in a much more intuitive way using handsets that you can see here. And this provides a real 3D picture, 3D immersion in the image, without having to do a lot of processing of the images, and it doesn't take as much time. As you can see from these this figure, over the past 15 years or so, there's been a massive explosion in research interest in virtual reality and across the world, and this has really taken off since about 2018. As the technology has developed further, you can see that there's been that massive upsurge in research interest. So this should play. So I'm just going to take you inside our virtual reality system now. So what we're doing here, this is the view you get when you put the headset on. You don't get the full 3D effect that you get within the headset, but you get the idea. So here the user is seeing a 3D echocardiogram of a patient's heart that's moving. They're looking down on the valves in the heart. These are the atrioventricular valves inside the heart. And so what they're doing is moving the data set around. They can cut into the data as they want to, and the image can be sliced in any plane that they like, and they can view it from any direction. And as you can see from this picture, you get a really nice moving image of the valves. You can see if there are any holes or where there might need to be a repair of the heart. And here you can also see that you can perform measurements within the system as well. And if you go to the next one, yeah. And this just shows that this technology is not just for one modality. We can load all the major modalities, so echocardiograms, CT, and MRI scans into this system, so that any real pre-procedural imaging can be loaded into the system and interrogated in the same way. So this is a CT scan of the heart. You can see the rib cage there that the user is cropping into with this cutting plane. And then this is just showing that some further work that we've been doing recently has been, again, I mentioned the catheter interventions where you can put plastic tubes into the veins or the arteries and deliver medical devices into the heart. So in this case, this is a problem called a sinus venosus atrial septal defect, where you insert a covered stent into one of the main veins in the heart and into the right atrium. And this helps to close the defect and to help to redirect some of the blood vessels that are abnormally connected. And so this is some work that we've been doing with the team at Evelina Children's Hospital, to see if we can help them plan this relatively complex procedure that requires quite an in-depth 3D understanding of the heart. So again, this is just a view from inside the heart, inside our system, and what you can see is we've developed a way to get an internal view of the heart by getting rid of the kind of normal contrast that you see on a CT scan, and you can get rid of that so you can see the internal structure of the heart. You can see the defect, which I just measured there, and then you can place this virtual stent inside the heart. With different sizes, so you can adjust the size of it so that you can see what might be the best size stent inside the patient, so you can help to potentially reduce device wastage and best plan a quick and effective procedure for your patient. Just going to hand over to John now.
So I think this is an example where we see the use of VR. This is unique amongst imaging modalities in that you can place a virtual device. So it allows us for operators to road test a procedure before doing it in a real patient. They can place the device before they go to the lab. The time saving, this is consistently faster than standard software. We wanted to provide better device and procedure selection with shorter procedure times, and we hope better outcomes with fewer complications. This is a complicated slide, but I want you to just note things like, aside from we get a number of cases where there's uncertainty about what to do, and we're often asked about opinions from other centers and sending data and awaiting replies, or printing, which involves, as Natasha said, some segmentation or pre-processing, and this all introduces delays in terms of the process. What we want to do is to eliminate uncertainty with VR. We can actually share imaging with other experts. We've done stuff with both within the UK and also, for example, with Canada, where the experts are actually looking at the same images at the same time in the same imaging and actively discussing the management of an individual patient and completely changing the approach to second opinion working and learning from each other about the best procedures. We also think, although our focus is on congenital heart disease, we're actually exploring with our adult cardiologists about where this might fit within acquired heart disease. And this is a picture of the newer clips which are being placed on mitral valves, or TAVIs, or new aortic valves are done by cathetermine. So these are things which we're looking at, given that we're co-located with adult cardiac services. This has hit the headlines and got great support from our patient groups in terms of the how this might impact on the patients. And we've got example family here have a real impact in terms of their families and their child, in terms of how we can impact on their care and choice of procedures. I'd like to thank the British Heart Foundation again for the support of our work. Thank you very much indeed for listening.
Thank you both. That was a fantastic presentation, and I know you and James and Natasha will be staying for questions after. Fantastic. I'd like to now introduce our next guest, Dr. Dimitris Doudesis. Dr. Doudesis will talk about an algorithm he developed with his team at the University of Edinburgh. Using this artificial intelligence could help doctors to diagnose heart attacks in women more accurately and quicker than ever before. Dimitris.
Hello, everyone. Just a second so I can share my screen. Hopefully you can see it fine.
Yep.
Great. Again, thank you very much for the invitation to talk about the research in this great BHF event. So my name is Dimitris Doudesis. I'm a postdoctoral researcher at the University of Edinburgh. I have a data science background, and I'm currently working in the BHF Centre for Cardiovascular Science at the University of Edinburgh. Heart attacks. As we mentioned already today, more than 1 million visits to the emergency department. There are more than 1 million emergency visits in the emergency department with symptoms of chest pain. This accounts for around 5% of all attendances in the United Kingdom. However, only 1 in 10 patients actually have been diagnosed with the heart attack. Moreover, this whole examination costs the NHS around £1 billion every year. So we wanted to address this problem. However, there is a challenge, and the challenge is because current guidelines recommend fixed cardiac troponin threshold for the assessment of patients with suspected heart attacks. So cardiac troponin is a biomarker that is being released by the heart when it's been injured, and the guidelines recommend this threshold to make the diagnosis. However, this threshold does not acknowledge that cardiac troponin is a continuous measure and varies within individuals. As a result, performance varies in important patient groups as concentrations are influenced by age, sex, and comorbidities. This limitation can be addressed using machine learning algorithms, which can take into account that each patient is different with different characteristics. This is a slide that shows that extensive prior research has shown that a single diagnostic threshold for the diagnosis of heart attacks cannot be optimized both for safety and for the diagnosis of heart attack, no matter where you set this threshold. And the first thing that we did in our research group was to evaluate how the current threshold to send a patient home from the emergency department performs in more than 48,000 patients in Scotland. You can see here that the performance, although it's great, there are specific groups such as those that present with symptoms quite early and they have changes on the electrocardiogram. The performance might not be as accepted, high as accepted. So we took this into account when we're developing our models. But the most important thing and the major challenge when it comes to the diagnosis of heart attack is the massive heterogeneity when you're assessing this patient. And you can see here how heterogeneous is this performance in older patients, in women, where the accuracy is quite low, unacceptably low, to be honest. So we took all these things into account, and we developed a machine learning algorithm called CodeACS, which stands for Collaboration for the Diagnosis and Evaluation of Acute Coronary Syndrome. To do that, we used a training data set from which we used patients from the High Stakes Registry Scotland. This was a randomized controlled trial led by Professor Nicholas Mills, funded by BHF. And we used information from 10,000 patients where they had a median age of 70 years and 62% were men, to develop a model. So our model takes into account the baseline characteristic of every patient, for example, their age, their sex, along with their clinical examination variables such as what was their heart rate, if they had a high blood pressure when they presented in the hospital, but and of course the cardiac troponin, which was the blood biomarker, and the value of that. So altogether, using machine learning, we combined, we calculated CodeACS. So CodeACS computes a score from 0 to 100 that expresses the likelihood of a patient having heart attack in the emergency department. We then moved on to externally validating our algorithms in more than six countries all over the world, in more than 10,000 patients, with a median age of 60 years and 65% being men. Now, what our algorithm shows was that they had an excellent performance. So this is an standard curve, a diagnostic performance metric that we use in machine learning, where the maximum value can be 1. So achieving a performance of 0.95 was excellent, whereas any model that achieving a performance of above 0.7 is considered excellent. Moreover, in this plot, we can see that the CodeACS score was consistent across the whole range of 0 to 100 that calculates probability. But what was important was like how we're going to implement our CodeACS as a clinical pathway. Right now, if you come to the emergency department, you need to have 2 blood tests before the diagnosis can be made to any patient with chest pain. However, algorithms can work with only 1 test and can safely send home 61% patient with an accuracy of 99.6, while it can send straight from the emergency department to the cardiology department in the hospital 10% of patients with a high accuracy of 75%. The troponin alone can achieve an accuracy of around 50% when it comes to that. However, this leaves in the middle 29% of patients that they require further testing. And this is another functionality of our newly developed algorithm that allows the second blood test to be taken to measure the cardiac troponin again, and then make a further decision in those patients that were not discharged or admitted to the hospital using the second test. So in our research, we saw that a further 11% of patients, again, have been sent home with a high accuracy of 99.6%. And again, we managed to send to the hospital, to admit to the hospital 5% more patients with an accuracy of 75%. So overall, in these 10,000 patients that we evaluated our model, 72% of patients were sent home quite fast, quite accurate, and they didn't have to wait in the emergency department for around 3 to 6 hours. And 15% of those patients actually were admitted in the hospital faster than the current approach, achieving a high accuracy to that. So we don't send everybody in, we send selected patients that they will be benefit from this early diagnosis and possible treatment. Here you can see that how the CodeACS algorithm performs in subgroups, and it was achieved a much more consistent performance compared to the previous slides that I saw earlier. but most likely it is the prototype app that we have developed that you might find interesting. And the idea was to develop the prototype app and implement the algorithm in this app, where the attending emergency clinician or cardiology nurse could use to get the code-DCS score. So I'm going to press play now. And you can see here that you can add the age, so a 60-year-old female with 8 hours of symptoms, slightly elevated heart rate and blood pressure, no changes in the ECG. They had, so eGFR is the value that measures your kidney function, hemoglobin, and the first troponin result. You can click submit, and you're getting the code-DCS score, which says how likely is for that patient to have a heart attack, and also add some recommendation. For example, in this case, that particular patient had the 6.4% of having a heart attack, which was high enough to not be sent home directly, but not high enough to be admitted to the hospital. So the recommendation is to remeasure the blood test again and input that in the model and get another updated probability. However, this app is acting as a decision support tool app to the attending clinician, and in no way they will be able to replace the judgment and the experience of clinician, doctors in the hospital. So as the takeaway message is that our newly developed algorithm can send patient home using a single troponin test, so just a blood test, which is quite easily available, right, around like 1 hour after you present to the hospital, so you don't have to wait for 6 hours. It can provide a specific individualized risk for every patient, while our current approach, they don't take into account that every person is different, men to women, older patient, younger patient, those with diabetes or not, they're not different, so they shouldn't be assessed based on the fixed threshold when it comes to such an important diagnosis. The other functionality is that it can work also with 2 tests, so you can get the first probability and then you can get the second test later on in the medicine department, and you can update that score so you can be more certain if you have any doubts. It gets a more consistent performance across all subgroups and not only overall. And the last and very important functionality as well is that the app has some settings that each hospital can set. So there are hospitals in the UK or all over the world that they might be understaffed right now, or being very busy, or they might not have the available resources. So each hospital can set their own diagnostic safety criteria or admit to the hospital criteria to adapt to their needs, with the hope to optimize patient flow in the emergency department and accurately diagnosing the heart attacks in the emergency department. I would like to finish with this slide of thanking, of course, the code-DCS research team, Professor Nicholas Mill, who was my supervisor and my current principal investigator, of course, some founders, and first and most important, BHF, that very kindly support us doing this very important and life-saving research. And I would be very willing to answer any questions. Thank you very much.
Demetrius, thank you very much indeed. That was I'm just looking at the future. I think it's really what we're seeing here. So all the guests are staying on for our Q&A session, and thank you all for submitting questions. You know the system. We've got a vote up system where if somebody puts in a question and it's something that you would have liked to have asked, you vote for it. So I'm going to try and go those in order. And so, and this is for all of you. What's been your best achievement so far as a researcher, and how do you motivate yourself with your work? Maybe I'll kick off with you, James, just as you started the day.
Well, thanks, Fearghal. That's a really interesting question. And I was lucky enough in my own research to identify a molecule that is a potential drug for the treatment of septic shock. And so septic shock is a big killer in the UK, but it's a big killer throughout the world. And so we have a new potential medicine for septic shock, and that's gone into the commercial world to be developed. So I was really privileged to be part of that. What motivates me is actually some very good examples today. I listen to other scientists. I listen to, science fiction becoming reality, and you get motivated by that. So just to be part of that is motivational, I think.
Okay, John and Natasha both.
Well, maybe I'll kick off where I think we first started introducing 3D. We're the first unit to introduce 3D echoes for structural heart disease. And initially when it comes in, people laughed at the images that we got because it was really quite challenging. And then a few years later, we used to see them all back at the courses we were running, and we published quite a lot about how to use these pictures, how to obtain these pictures, how to use them in your clinical workflow. And years later, there's like international guidelines and all the rest of it. So I think it's that translation from what's an idea to actually becoming part of standard practice is the part I like to see, that actually goes somewhere and becomes embedded. Tash, you want to add?
Yeah, I think it's I think also the stuff that we're seeing now about kind of data science as well. So integrating, the huge amounts of data we have from genetics, from databases, that can all be integrated into the ongoing work, so that you can combine data science along with kind of imaging research, other types of research. I think that's going to be a major breakthrough in the future as well, and something, hopefully can be integrated into a lot of work going forward.
Okay, and Demetrius?
Yeah, it is something similar. So in my PhD, we also developed something very similar for the diagnosis of heart failure that you very rightfully mentioned at the beginning. Heart failure and heart attacks are the most two common conditions. And right now, after 4 years, and the heart failure work has been published actually in the British Medical Journal, we are in the process of trying to implement these things, and it's super rewarding seeing your research trying to be implemented in the NHS and see the possible impact that this can have these two people's and patient lives. And in terms of like what motivates me is like a person like me has a quite good skill set in terms of like data science programming. It's a very hot topic. You can get quite nice jobs in industry, high-paying jobs, but like doing data science for a reason, it was motivates me and guides me to do this kind of research.
Okay, thank you all. This is a specific for James. What is the biggest breakthrough in 2022 in cardiovascular research, BHF funded or not, in your opinion?
That's a nice, easy one, isn't it? I mean, I think that there's been a huge number of breakthroughs, some of which we've heard today. If I have to choose one, and this is just going to be a personal preference, I'm going to be biased in terms of Glasgow, which is where my group is, and I'd refer to the Ironman study. So this is a study of people who have had people in heart failure, and it's a little appreciated fact that those people are often iron deficient. And so this study tested the effect of giving iron supplements to people with heart failure. And they found actually that it reduced the incidence of admission into hospital and complications. And so the reason I like that is because it's kind of a simple intervention. Iron supplements are available and could be easily and cheaply rolled out. So I think it's a neat bit of science that has very kind of immediate clinical benefit.
And of course, for those who are watching and may not have seen our last program reflected on that. This is for John and Natasha, and it's predicated on a statement, so I don't know the truth or otherwise of this, but it says your heartbeat is unique as your fingerprint. Through the VR technology, would it be possible to identify people by their heart, like how individuals can be identified by dental records?
I think they're very one of the reasons we've gone down the VR route is because cardiac lesions are so individual and the structural lesions are so individual. I hesitate for a normal heart that you would be able to pick someone out just from what we look at. I don't think it's quite the same as a fingerprint. I think there certainly, you see some individual things that are so rare that you can place it to sometimes only to a very few patients that you know who may have a particular condition, but I don't think we're quite at the point of identifying people through their scans at the moment. And you know, we might ask why we want to do that, but we're not quite at that point at the moment.
Yeah. Use the fingerprint first.
Yeah.
So this is one for James directly. It says, I've seen a lot of funding for regenerative medicine at the BHF recently, as mentioned today. Is this the future of treating cardiovascular diseases?
Very good question. I think regenerative medicine is a very, very interesting and exciting field of cardiovascular research. It's not the future on its own. I think that there are applications where regenerative technologies, so cell therapies, gene therapies, protein therapies, such as Professor Jacka's, will be effective. But I think we need a whole range of weapons in our armory to fight cardiovascular disease. And that will range from traditional drugs, such as statins and other drugs, cell and gene therapies, regenerative medicine, if you like, through to advances in surgical techniques and support for patients after cardiovascular events. So I think it's a tremendously exciting area. The BHF is very proud of its centres for regenerative medicine that it funds, and it will be an important weapon in the armoury, but not on its own.
This is a question talking about tech, but it says, will this tech be available to all patients or to a select? And they're referring to a specific patient, and it's their son who's 26, has full AVSD Fontan and is now in palliative care and no surgery plans. Would he be given a chance to review his situ with new tech?
The answer at the moment is not yet. This comes down to regulatory approval of this type of technology. For any devices which have been used to make clinical decisions, we have to go through a regulatory framework. So we can look at things, if you like, retrospectively, but we can't yet go into the sort of thing of saying, look, we're prospectively going to change somebody's care according to what we show in a VR image. And from the situation described, it doesn't sound like that would fundamentally impact in terms of the approach being taken there. In all honesty, we have to jump through some hoops. Like, we recently published a paper, which is one of the first papers where we looked at VR technology and said, well, are the measurements accurate? We've shown measurements you saw it on the screen, but are they accurate? So we have to go right back to looking at structures, where Tash was scanning some structures of known dimensions, and we have to prove that what we measure is accurate. And and so there's some hoops we have to do before we can bring this into practice before patients have procedures.
Okay, thank you. A question for both you and Natasha. John, is this VR tool just for cardiologists? Understand that that's the work you've been doing, or can the VR be developed for other surgeries?
Yeah, that's a great question. So yeah, we obviously have been focused on the heart because that's our area of interest and our area of expertise, and we can see the the real potential for its use there. But absolutely not. There's a lot of potential of areas outside the heart where it could be used, and there is already research going on with other groups for using where especially imaging is really important for planning. So things like ear, nose, and throat procedures, maxillofacial kind of reconstructive work. Liver surgery, abdominal surgery, the possibilities are really quite endless, especially, as I said, for these areas where imaging is a really important initial input, where surgeons can get a better understanding of 3D relationships and what they'll find when they actually go in there. It's a real tool for other areas as well.
Okay. Next most voted question is, are there any clinical trials specific and looking to a specific piece of research? Any trials or research studies for LVH HCM running where you require people to participate? James, maybe that would be in your field, no?
So That's a really good question. And it just reminds me of something that we didn't speak about in this session. And that's our Big Beat Challenge. The BHF recently funded an award of £30 million to investigate genetic therapies for inherited cardiac muscle diseases of the sort that you refer to. So this award was made to Professor Hugh Watkins in Oxford and aims over the next 5 to 7 years to get into the clinic. And the idea here is that inherited cardiac muscle diseases are caused by single spelling mistakes in the DNA. We know where those spelling mistakes are, and now Hugh and his team are going to develop tools to be able to go in and correct those spelling mistakes. This is really, really exciting because this is curative, you know, and in a lot of what we've talked about today is treating. This would be curative. And so in 5 to 7 years, that team hopes to be starting the clinical trials that will validate this approach. And I think that it's exciting for patients with heart muscle diseases, but it will also prove the principle that for lots of inherited diseases, we may be able to take a genetic approach to correcting the defect. So it doesn't directly answer the question. I think if you refer to our patient helpline, they may be able to give you specific information about ongoing trials. But I did want to just flag up the Big Beat Challenge because I think it's one of the most exciting things that we're doing.
For those again of you who haven't seen, we focused on this in Alive and Ticking. Can't quite remember 2 or 3 back, but it's mind-blowing really what's involved in that overall project. James, this is for you too. Is there something you're most excited about for next year's research?
Big Beat Challenge probably. And we've covered Regen Med. I'm a huge enthusiast for regenerative medicine. I think actually, if I had to highlight another area, it's big data. And I think there's a huge amount of data now about our health from our medical records, but also we're all wearing devices which are reading out various sort of aspects of our health. The challenge, of course, is to process all of that information into something meaningful or clinically actionable. And I think we've heard today about some of the algorithms that can start to do that. And so I think we are at an important watershed moment in terms of big data in cardiovascular health and how that can be analyzed for patient benefit. And just to say that, you know, the BHF recognized this a number of years ago when we established the BHF Data Science Center. So the BHF Data Science Center is able to give researchers access to big data to really start to tackle these problems. And just one stat, which I think is mind-blowing, that during COVID, the BHF Data Center was part of a consortium that linked 96% of the UK's population medical records for this analysis to see what was going on during COVID. You know, that's kind of mind-blowing. We have the power now to handle this data on scale. And I think that, you know, patient benefits will start to come out of that very soon.
Yeah, it's a sort of a follow-up question, but tech is clearly the way forward for better diagnosis. And does the BHF prioritize tech projects that have patient benefits over anything else? Says the questioner.
A very good question. We are really excited by tech projects, and we're really excited by better diagnosis. But, you know, better diagnosis is just one of the things that we do. We want to prevent cardiovascular disease. We want to be able to identify it early through better diagnosis, but we need better treatments. You know, for some diseases where we're able to diagnose it early, but we don't have a treatment, that's really heartbreaking. And so I think we need to push on all of these areas. We want to prevent, we want to diagnose, we want to treat, and ultimately we want to cure. And so across our research portfolio, which is about £450 million worth of active research at the moment, we are pushing on all of those fronts. And we think together, these initiatives will see benefits for patients.
Thanks, James. This one's for Demetrius. I can sense a bit of excitement in this question. What's next for your research? What will 2023 bring?
Thank you. That's an excellent question. So as I said, we have developed two tools, two algorithms, one for heart failure and one for heart attack. So the next plan is actually to make this into like medical devices, like products. As John mentioned, we cannot just go out and just starting using them. We need to get the proper regulation approvals, UK CA marking, and to prove in prospective patients that our data are actually representative and it is safe enough to use it. But I would like to mention that actually BHF funds one of these projects right now for the heart failure one through the Translational Board. And I think this shows how the BHF actually puts funds and resources into these new tech solutions. So I really like to see how things progressing and taking this from the research environment and the publication to actually implementation is actually what 2023 will bring.
Okay, can I just ask you a quick question on that? Could you end up that, I'm not saying self-diagnosis, but remote diagnosis feeding back in?
So this is, you just described an idea that we have. So we want actually to, our algorithm works in the emergency department. So patient presenting with symptoms of heart failure or heart attack, what is the diagnosis, if it is something alternative or not. So actually we're thinking of going one step back and go to the GP level to prevention care and measure different biomarkers related to different diseases and see how the risk score might, which in this case will be a prognostic tool, might change the outcomes or change the treatment of some patients, hopefully also improve their outcomes.
Okay. You always learn in research, but this next question is asking, what's been a learning curve in all of your research this year? Something that stood out. John, you're smiling.
Lots of learning curves. You get into, I think one of the learning curves for us is who you're reliant on. And one of the learning curves we had, we showed the pictures with some of the glasses that we had, and we were very excited about a particular type of glasses we were going to be using for this project. And then of course, that company doesn't succeed and folds up. And so the main one of the learning points we had is your plan B. Your plan B, if you, and we can very effectively move sideways, is unexpected things can and do happen, and we have to think of a way around it if things always don't go to plan. So we've had some recent bitter experience on that, but we've come out the other side.
Yeah, good advice. Good advice. Demetrius, biggest learning curve this year?
So not this year. This is actually for the last couple of years, which was like how to actually collaborate and work together with domain experts, in this case, clinicians. Coming from a data science background, I see things different. And it was very important to actually be in the hospital, work with clinicians and understand from the inside what the problem was, rather than me trying to solve it on my own. So I would say this was the learning of the last 2-3 years.
Okay, and James?
Oh, I think a big learning over the last year or so is that you can be right and wrong at the same time in research. So you think you understand a system, actually, but you don't understand it completely. And when actually you realize that, other opportunities open up. So science is wonderful that you can be right and wrong at the same time, and new doors can open up for your research to go into different ways.
Okay, thanks very much. There's a question here on the drug for sepsis you mentioned, sounds very exciting. Where can we find out more about this? If you want to jump in with a quick answer, please do. If not, our team will put up a link to some of that if you can provide it.
I think that's the simplest thing to do. We'll put up a link for people on that one.
There's a question here for you, John and Natasha. It says, what are the limitations of the VR software? Can I make an add to that? What are the real horizons also?
Oh, well, this virtual reality kind of encloses you in the glasses space. There's a whole lot of other different technologies. What about the images where you don't need a pair of glasses, where you can see all of this in front of you by projection? You don't need any of this kit, and you can just see things in. And you know, there's some what I think called augmented reality, where we can see the world around as well as the structure of interest. And then there's the stuff where we can say, well, look, what goes on, what can we see without anything? There's some other stuff where we're talking to our engineers where you can give images, for example, physical properties. So as you're trying to say, do a procedure and you're working with the image, that you feel a tugging or whatever, a buzzing when you're, you can give these, there's just limitless possibilities as to how you can handle this. Tash, do you want to?
Yeah, I think really the simulation aspect. So that's what a lot of our clinicians and surgeons are asking for, is we're talking about implanting devices, but is there a way for you to be able to simulate what will actually happen in real life and how it can move with the tissues, how it can interact with the tissues? And again, I think that's going to be sort of integrating kind of data science and artificial intelligence and kind of fluid dynamics and things like that will definitely bring that and move that forward. And that would be a huge leap for us in planning procedures.
Okay, unfortunately now we're out of time, but I'd like to thank you all very much. We're going to miss out on one question, which is talking about speeding up the regulatory process as was done for COVID vaccine. And is there a way to safely do that? But maybe we'll address that at a point in the future. Or we could get a reply, James, and then post it up. Now to our polling question. How would you rate your understanding of BHF funded research in the last year? Rate 1 is very low or 5 high. If you could vote now, please. In the meantime, just like to thank you for watching this edition of Live and Ticking. We hope you've enjoyed hearing from all of our brilliant speakers. If we haven't managed to answer your question today, then we can encourage you to visit our Heart Helpline, where you can contact our dedicated clinical team about your query. All our incredible research is funded 100% by you, the public. If you've been inspired by the amazing science you've heard today, then all donations to support our life-saving work are very much appreciated. And there's a link to donate should you wish to do so at the end of the event. And our Live and Ticking series are monthly. We strive to produce the best events possible. Your feedback and comments are crucial to help plan and develop future events. So we ask if you can complete the survey at the end of this event or through an email that you receive in the coming days. But in the meantime, thank you again for joining us. Happy Christmas and goodbye.